Alright, this is gonna be really short and out there, but fuck it. We're gonna talk about hemorrhoids because I've been struggling with hemorrhoids for a little bit. And I wanted to give a nice conversation about hemorrhoids with AI. And it's funny because it wrote up a bunch of field reports. So we can talk about the historical tapestry of hemorrhoidal disease, where we trace the conceptual evolution of hemorrhoidal disease from ancient curses to a physiological entity. The historical narrative reveals a constant struggle to define the condition, moving from divine punishment to a multifactorial pathophysiological process, with therapeutic principles remaining remarkably consistent across millennia. So, the earliest known reference to hemorrhoids are found in ancient Egyptian papyruses, establishing the condition as one of the oldest recorded human ailments. However, the most vivid early accounts emerge from theological contexts. In the Old Testament, the Philistines of Ashdod were smitten with hemorrhoids, a term believed to be an ancient derivative of hemorrhoids. The book of Samuel describes these afflictions as divine punishment, a theme echoed in Deuteronomy, where the botch of Egypt and hemorrhoids are listed among the curses for disobedience. The transition from theological to rational explanation is attributed to Hippocrates. In his treatise on hemorrhoids, he moved beyond supernatural explanations, approaching the pathophysiology and treatment systematically. Hippocrates described methods for excision and cautery, establishing a surgical tradition that would persist for centuries. Remarkably, an analysis of historical texts reveals that the principles of therapy, surgical, non-surgical, ambulatory, and medical have remained substantially unchanged since his time. For nearly 2,000 years, humoral theory dominated medical thought. It wasn't until the Renaissance and the advent of anatomical dissection that a clearer picture emerged. The debate over the venous drainage of hemorrhoids, particularly its connection to the portal system, became a point of significant anatomical contention. This confusion perpetuated undocumented theories about their formation, particularly regarding their relationship with portal hypertension, a misconception that persisted well into the modern era. The single most significant conceptual lead occurred in 1975, when Thomson published The Nature of Hemorrhoids. This work introduced the game-changing concept that hemorrhoids are not a disease in themselves, but normal vascular structures, anal cushions. This reframing proposed that hemorrhoidal disease arises not from the presence of these cushions, but from their pathological enlargement and distal displacement. So essentially what we note with historical interest, the role of hemorrhoids in geopolitical events. It's actually widely documented that Napoleon Bonaparte suffered acutely from hemorrhoids on the eve of the Battle of Waterloo in June 1815. The pain prevented him from riding his horse to survey the battlefield, contributing to tactical errors and communication delays that many historians believe played a role in his decisive defeat. Thus, a single anorectopathology arguably altered the course of European history. The history of hemorrhoids is a microcosm of medical history itself, a journey from divine wrath to anatomical curiosity, and finally to a sophisticated understanding of a normal structure's pathological transformation. Now I want to dive into biological and pathophysiological mechanisms, where we elucidate the modern understanding of hemorrhoids as a multifactorial disease involving vascular malformations, connective tissue degradation, and mechanical displacement, and synthesizing current knowledge on the anatomy, histology, and pathophysiology of the internal hemorrhoidal plexus. Contrary to colloquial usage, hemorrhoids are normal anatomical structures. The internal hemorrhoidal plexus consists of three distinct soft vascular cushions located on the left lateral, right anterior, and right posterior positions of the anal canal. These are covered by insensate transitional columnar epithelium above the dentate line. They become clinically significant and thus termed disease only when they become symptomatic through bleeding or prolapse. The internal hemorrhoidal plexus is a complex vascular network receiving blood from the superior and middle rectal arteries. The terminal branches of these arteries penetrate the rectal wall to feed the cushions. Venous drainage is unique, occurring through all three rectal veins: superior, portal system, middle, and inferior systemic circulation, creating a physiological crossroads where arterial, systemic, venous, and portal venous blood mix with sinusoids. The defining feature is the presence of arteriolar venular anastomosis, medical language. Most of these lack a muscular wall and are considered sinusoids, forming a spongy, dilated vascular network. This histology has been likened to pineal erectile tissue, as these sinusoids fill with blood to create a turgid, space-occupying structure crucial for fine continence. The cushions are not merely bags of veins. Their non-vascular component is essential for maintaining position. So we have Treitz muscle. This is a musculofibrous structure with two parts. The anal submucosal muscle fixes the cushions to the internal anal sphincter, while the mucosal suspensory ligament, Park's ligament, anchors them to the conjoined longitudinal muscle. And we have connective tissue, elastic and collagenous fibers surrounding the sinusoids, providing structural integrity. Hemorrhoidal disease results from the failure of these support structures. The dominant theory is the sliding anal canal, or anal cushion displacement theory. When Treitz muscle deteriorates and the connective tissue fragments, the cushions lose their anchoring and slide distally down the anal canal. This prolapse is graded from 1 non-prolapsing to 4 irreducible. Concurrent factors include hyperperfusion. Failure of the sphincteric mechanism in the terminal arterioles leads to sinusoidal engorgement. Venous outflow obstruction, straining during defecation, increases intra-abdominal pressure, impeding venous return and exacerbating engorgement. Collagen abnormalities. Emerging research suggests abnormalities in collagen composition may contribute to the weakening of the supporting connective tissue, predisposing individuals to the disease. The internal anal sphincter is responsible for 60 to 80% of resting anal pressure. However, it leaves a small gap. The anal cushions engorged under resting pressure fill this gap and contribute 15 to 20% to anal continence. This volume-occupying effect is vital for maintaining a watertight seal and allows for the fine discrimination of rectal contents, gas, liquid, or solid. Hemorrhoidal disease is best understood as a failure of the structural integrity of a specialized vascular organ. The interplay between vascular engorgement and connective tissue degradation leads to displacement, transforming a vital physiological structure into a pathological entity. All right, I'm pretty sure this is our last field report. I know this is way different from talking about astrology, but I'm trying to also talk about AI on this channel and the advancements of AI and technology, and specifically DeepSeek and what it can do for us as human beings. So this report is going over the clinical evolution and future trajectories. This report reviews the rapidly evolving landscape of hemorrhoid management. From foundational conservative measures to cutting-edge interventions, the field is moving toward less invasive, anatomically sparing procedures, and we analyze current guidelines and future trends shaping the standard of care. Hemorrhoidal disease affects approximately 10 million individuals in the United States alone, significantly impairing quality of life through bleeding, pain, and prolapse. Despite centuries of study, optimal therapy for every stage remains a topic of investigation. The cornerstone of initial treatment remains surprisingly simple and unchanged: increased dietary fiber and water intake, and avoidance of straining. Pharmacologically phlebotomic agents, for example flavonoids, are used to improve venous tone and reduce symptoms, though recurrence rates are high, up to 80% within 3 to 6 months. For persistent symptoms, a tiered approach is employed based on grade, treatment modality, indications, efficacy, and notes. So rubber band ligation, grades 1 through 3, internal, 89% symptom resolution, gold standard may need repetition, 20%. Sclerotherapy, grades 1 through 2, internal, short-term efficiency, 70 through 85%, long-term remission, only 33%. New foams show promise. essentially what I'm trying to get at is just the future of hemorrhoid management lies in personalization and minimal invasion. By understanding the pathophysiology and leveraging new technologies, the goal is shifting from simple excision to preservation and restoration of normal anal anatomy and function, truly embodying the principle of primum non nocere. Thank you for watching this video. Subscribe, like, and comment, and I will see you in the next one talking about who even knows what. Peace and love.